This is Brent of the Brookbush Institute, and in this video we're bringing you another manual technique. Now, if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist following the laws regarding scope of practice in your state or region. That means athletic trainers, chiropractors, physical therapists, osteopaths, licensed massage therapists. You are likely in the clear to do these techniques. Personal trainers, this probably does not fall within your scope of practice, although you might be able to use the palpation portion of this video to aid in learning your functional anatomy in an educational setting supervised by a licensed manual therapist. Now, before we place our hands on a patient or client, it is important that we assess and have a good rationale for doing so. And of course, if we're going to assess, then we should be reassessing to ensure that the manual technique we're using is effective and we have a good rationale for continuing to use that technique. In this video, we're going to go over static manual release of the Erector Spinae muscles. I'm going to have my friend Melissa come out. She's going to help me demonstrate. We're going to use the same palpate and compress technique we've been using for all of our static manual release videos, using that four-step process of differentiating, knowing where our common trigger points are, knowing what not to press on, and of course getting our patient and client in good position and us in good position so that we have good technique. Starting with the differentiation of tissues, your Erector Spinae are fairly superficial. And providing we're not talking about trying to differentiate the various Erector Spinae muscles, they're actually not that hard to palpate. The three muscles combined create a column of tissue on either side of the spine. I think you guys instinctually knew this, right? This valley is created by the skin and underlying fascia being tacked down to the spinous process, and then the thoracolumbar fascia and fascia along the spine here all the way into like our cervicothoracic fascia create these columns wrapping around the Erector Spinae muscles that create hills on either side. For our palpation, the only thing we have to consider outside of knowing where these hills are is what direction of a diagonal these fibers go in, because we're going to want to go back to that stroke perpendicularly to find the densest fascicles and then go parallel along the dense fiber to find the nodule hyperactive point trigger point, right? So here's how the diagonals work. Most of the Erector Spinae, in fact, all of the Erector Spinae, have a diagonal that goes from lumbar spine essentially to shoulder. If you think in that direction, from inferior medial to superior lateral, and then you just drew parallel lines in your head, that's the direction of the Erector Spinae. The only muscles that are a little different, being erectors of the spine that can also develop trigger points, is our multifidi, which our trigger points for our multifidi are usually in our lumbar spine. Here is what we're talking about, and they go in the other direction. They go from inferior lateral to superior medial. If I'm going to palpate tissues that run this way again, so we're back to Erector Spinae, I'm going to set up my hips so they're even with Melissa's hips, and then my hands are going to be going in the direction of Melissa's head, and that would be my perpendicular strokes. So that's not too bad. When I do my Erector Spinae, I'm facing this way. And then I can just survey the length of my Erector Spinae. I'm just kind of picking up my hand, strumming over the tissues. Now it helps to know where your trigger points are. Your two common trigger points that we're usually releasing in the Erector Spinae are right in the middle of the lumbar spine, like in line with somewhere between L2 and L4, and then just above the thoracolumbar junction there tends to be another trigger point. So if I know that, I might go right to those points first just to see if I can narrow this search down a little bit. And when I find really dense fascicles, again, I'm then going to go in line with the fiber, search the whole fiber here for a nodule, an acute point of density, an acute point of overactivity, and then you guys can use one of your various comfortable hand grips, either thumb over thumb, just again leaning in. You can use the technique I like to use, as you guys know, which is kind of having that dummy thumb and then either putting my piezoform hamate over my thumb or putting my thumb in my thenar groove here. Right? So in this case, I think I'm going to do piezoform hamate. And I'm just going to hold 30 seconds to 2 minutes. To kind of pin down this tissue, guys, notice I'm not pushing straight down, I'm kind of pushing this way. That does help to keep me from playing that game of like put your finger on top of a marble. And it just like keeps shooting out this way. I tend to not only push down, but push a little bit so that I'm kind of like bowing this tissue this way, which holds that trigger point underneath my thumb. Now, if I want to switch around and do the multifidi, right? Maybe I've done all of my Erector Spinae. If I want to switch around and do my multifidi, I'm then going to put my hips level with Melissa's shoulders, and I'm now facing her opposite hip. I can then go through and guys, these are going to be lumbar spine, right? Otherwise, as we get up in the thoracic spine, the multifidi are not well developed in the thoracic spine, and of course, when we do the neck, that's a whole different set of techniques, which we talked about in a different video. So if we're doing multifidi, it's going to be lumbar spine. We're going to go this way, this direction, a little closer to our spinous process until we find an acute point of overactivity or density. It does help to kind of bring the pants down a little bit so that you don't have to feel through another layer of clothing, right? You already have the skin to feel through, you already have some adipose tissue, fascia. There's a lot going on back here that we gotta feel through to just feel these small increases in tissue density. And in fact, the common trigger point here is actually somewhere between, in that little divot between our PSIS and then the spinous process of L4, L5. Like right in here, there's like a very common trigger point. All right, so if I push in there, how does that feel, Melissa? Yeah, a little tender. This is definitely a common trigger point. As far as, is there anything in this area that maybe we shouldn't put our hands on? Well, no. Providing that we're staying close to the vertebral column, our transverse processes, for the most part, protect us from being able to do damage to things that would be deeper and more sensitive. It would be pretty hard, for example, for me to push down so hard that I damaged a nerve or damaged, I don't know, an internal organ. Like, you'd have to be way out here to get to some of your internal organs. I know people worry about that, but the transverse processes protect us pretty well. Of course, if somebody had acute lumbar pathology, like a nerve root adhesion that was kind of new, or they were experiencing some pretty significant sciatic symptoms, or you had like a lumbar herniation, obviously be careful. You know, don't go in and push down as hard as you possibly can. It's not so much that this is one of those things that you need to watch where you put your hands, but maybe how you put your hands. If I knew somebody was very sensitive to posterior to anterior pressure, I might even bring the table up a little higher so that I can get a little bit more of a horizontal pressure so that I'm not getting so much of this. We can still pin tissues pretty good by pushing them towards the spinous process. How's that feel, Melissa? Yep, it's still very tender. Of course, she has no lumbar pathology that we need to worry about, but you guys can kind of imagine how this would be helpful. Back to client position. Notice when I wanted a more horizontal direction, I raised the table. When I want a more vertical direction, of course, I'm going to lower the table. What you don't want to do, and this is just, if you think about it, some common sense, you don't want a high table and trying to be pushing down. We don't want arms like this. We want arms straight. We want to use our fingers maybe to palpate, just because we need that sensitivity. But then when we've palpated the tissue that we need and we're just applying pressure, we really want to apply pressure not with hand strength and arm strength, but just by leaning our body and using body weight. I'm actually not using any strength at all here. My elbows are just shy of locked, my arms are nice and straight, and I push down. I can tell you guys, this is where having mirrors in your office comes in handy. I know not everybody has that, but if you have mirrors in your office, check your own posture every once in a while. I know we put mirrors in offices for assessments of our patients, but I think sometimes we need as much assessment on our technique and posture while we work. All right, so just a real quick recap, guys. Common trigger points: just above the thoracolumbar junction, right in the middle of the lumbar spine, and then in that little soft area between the PSIS and spinous process of L4, L5, usually a multifidi trigger point. Erector spinae, perpendicular strokes are this way because those fibers run this way. Multifidi run this way, so we set up this way. Stay tuned for our close-up recap. So you guys can see the trigger points I've marked out here are the most common trigger points in the erector spinae and the multifidi. One just above the thoracolumbar junction, the other right in the middle of the lumbar spine. And then of course that multifidi trigger point often occurs right between the PSIS and the spinous process of L4, L5 and that soft tissue divot there. Now if we're going to palpate and release the erector spinae because they have a inferior medial to superior lateral diagonal, I want to line my hips up with Melissa's hips, and then my hands are kind of going in the direction towards her opposite shoulder. I'm going to do my perpendicular strokes, strumming these fibers just like guitar strings, looking for the densest or tensest guitar strings. Once I find the densest tissues, I then go along the length of that tissue to see if there's any sort of nodule or acute point of hyperactivity, a trigger point. Once I find that point, then I can go, the palpating thumb becomes my dummy thumb, and I can just place either my thenar groove over that thumb or my pisiform hamate over that thumb, straighten out my arms, lean in, apply pressure for 30 seconds to 2 minutes. Once I get a release there, then maybe I keep palpating, keep strumming all these fibers, looking for any other trigger points. You have to remember that your erector spinae is made up of tons of fascicles, right, that all run in parallel this way. So it is possible to have multiple trigger points at multiple different levels. These are simply the most common trigger points. Now for the multifidus, remember that instead of going this way, since the multifidi go superior medial to inferior lateral, right, they go this way, that I have to turn myself around. So now my hips are in line with Melissa's shoulders, my hands going towards her opposite hip, and it's a little different palpation, it's a little different feel than these big erector spinae muscles. The multifidi are usually a little flatter, but you're going to look for the densest fascicles. Once you find them, once again, we'll go along that fascicle to find any tender nodule. And then once I find it, I can either do my thumb over thumb, pisiform hamate over thumb, or I could even do like thenar groove over thumb like this, holding for 30 seconds to 2 minutes until I get a release. So there you have it. Knowing your functional anatomy will definitely help your manual technique. It'll help you differentiate structures so that you can place your hands where they need to be, as well as make you aware of the sensitive structures around the tissue that you're trying to target. Things like nerves and lymph nodes and arteries. Make sure that if you're going to place your hands on a patient that you have done an assessment and have a good rationale for placing your hands on that patient. And if you're going to assess, make sure you reassess to ensure that your technique was effective and you have a good rationale for using that technique again. Now with manual therapy, one-on-one live education is incredibly important. Please be looking for opportunities like workshops and mentorships and maybe even classes at your local university that can get you some one-on-one individual instruction, or at least some live classroom instruction, so that you've had a chance to be critiqued and mentored by somebody senior to you with some experience in manual therapy techniques. And before you bring this stuff back to your rehab, fitness, or performance setting, please practice on colleagues. There is no substitute for practice, and it is going to take a while to get accustomed to some of the techniques that we show in these manual technique videos. Don't expect to learn them in 2 or 3 or even 5 minutes. You want to have hours of experience under your belt working on various different body sizes and shapes, so that when you do get that first paying client, first paying customer, and you're really trying to make a good positive impact, really trying to promote better outcomes, you feel comfortable with that technique. I look forward to hearing about your outcomes and hearing your questions in the comments section of this video. I'll talk with you soon.